So I'm Becky Thursfield and I'm a respiratory consultant from Hay Hospital up in Liverpool. I'd like to thank you for asking me to present this work today, and I'm sorry that I can't be there in person. So I will just start off by showing you these slides. So the OCELOT study, the aim of the OCELOT study is to develop a core outcome set lifelong for people born with esophageal atresia and or tracheoesophageal fistula. You can see by those logos on that screen that it's been a real team effort to get it to the point that we're at. So when I started doing research in this area, it became very evident that we needed a core outcome set in order to further research. And that's a good place to start, is what is a core outcome set and why do we need them? I'm going to hand over to Sarah Gorst at this point, who will explain more about that.
Hi everyone, so my name is Sarah and I'm a researcher at the University of Liverpool, and I work with an initiative called COMET. So we provide methodological support and resources to people all over the world who are developing core outcome sets, and I've been involved in several core outcome sets across a range of health conditions. So I'll just start by giving you an introduction to what core outcome sets are and why we need them. There we go. Okay, so let's start off by looking at how healthcare treatments are developed. So to help patients, doctors and other health professionals make decisions about treatments, we need evidence about what works best. And so treatments are developed and tested by researchers to make sure that they work and that they're safe. And to do this, researchers need to look at the effects those treatments have on patients. And researchers do this by measuring an outcome. So for example, in a study of how well a new asthma treatment works, outcomes might include things like inhaler use, A&E visits, lung function, or the ability to perform daily activities. But there's some challenges when it comes to measuring outcomes. So at the moment, different studies looking at treatments for the same health condition often measure different outcomes. So for instance, if we imagine two studies of how to treat migraine, study A, researchers might be measuring days off sick as an outcome, whereas in study B, researchers might measure symptoms of pain as an outcome. And so when these two studies are finished, we can't compare or combine their results because they've used different outcomes. And this is because we would not be comparing like with like. So how can we solve this problem? Well, if all studies in a particular health condition use the same set of outcomes, they could all be compared and combined. And this would reduce waste by making the best use of all research. When a set of the main outcomes has been agreed for a specific health condition, we call it a core outcome set. And if all studies in a particular condition, such as migraine or asthma or anything, if they all measured and reported all of these core outcomes, it means that we could bring them together and get a better understanding of which treatments work best because we'd have the evidence. So how are core outcomes agreed upon? Well, deciding on which outcomes should be core requires a great deal of discussion. So core outcome sets have to be relevant to patients, carers and health professionals. And there's sometimes other groups as well, depending on the nature of the core outcome set. But we need to ensure that the people who are working on the development of core outcome sets have the expertise. And so patients, carers and professionals we recommend that they are always included in the development to agree on the core outcomes. And to do this, we often use consensus methods. Now, consensus methods are surveys, meetings and discussions where opinions of relevant experts are drawn together. And sadly, patients and carers haven't always been involved in this type of work, but now we are beginning to see more and more that their views are being included, as we're recognising the importance of their first-hand experience of living with the condition. So why is it so important to involve patients? So as I've said a little bit then, but I'll just go on a bit further. So core outcome sets need to include the outcomes that are most relevant to the people who live with the condition, so patients and carers. And the best way to do this is to involve these people in the development of the core outcome set. And we've seen, so in core outcome sets across many different areas, there's examples of how involving patients has identified an outcome that was important to them as a group, but it might have been overlooked if practitioners had done the work on their own. And so it has been shown to be vital to have the inclusion of patients and their family members. So how are core outcome sets used when they've been agreed? Well, when a core outcome set has been agreed and finalised, the hope is that researchers and clinicians will use it in all studies or practice, if relevant, for a particular condition, and they can then add in other outcomes if they wish. So the core outcome set includes the core outcomes, and these are those that should be measured as a minimum in all studies for a particular health condition. So researchers are also able to measure other outcomes that they may be interested in, depending on what their study is looking at. It's just as long as that all researchers measure this core set. So, for example, if every migraine study used the same core outcome set, their findings could be compared and combined correctly. And in the long run, this would improve the quality of information about which treatments work and which don't. And this will help people to make better choices.
Okay, thanks, Sarah. So we've established that we need a core outcome set. We don't have one. And so we formed a steering group within the UK, incorporating 8 different UK centres or institutions. And on that steering group, we have a wide variety of people. We have, most importantly, people with esophageal atresia and representatives of people with esophageal atresia. We have dietitians moving around in that diagram there. We have surgeons, respiratory physiotherapists, respiratory paediatrician, that's myself, ENT, psychologist, speech and language therapist, research scientists, all making up that group and looking into developing this core outcome set. Early on, we had formed a collaboration with Ernica, who were doing different but aligned work at that time, and so we joined forces, strengthening both of those projects. But it was quickly established we needed further international collaboration. If we were going to develop a core outcome set, we want it to be used worldwide. We don't just want a core outcome set that is relevant for people within the UK, because then when we want to do research, we say, well, we can't combine our research with those over in Australia or in the States, because our core outcome sets are not relevant to that population. So that clearly wasn't the way to go. And so we established that we needed further international collaboration. That was one of the key factors, the key focuses for the steering group, was this really needed to be an international collaboration. And the next real focal point was the fact that it needed to have patient and patient representation integral to the whole project, and that was really at the heart of the entire project. So what did we do? Well, having established we need a core outcome set, what we're going to do, you need to go to the literature. What is out in there in the literature at the moment? The Ernica project had already done a large systematic review covering everything we would have wanted to do that. So we just needed to bring it up to date, because that had stopped a little while before we started this piece of work. And then following that literature review, or alongside it, we did some PPIE events, really getting the public and patients involved and engaged. There was a workshop that we did through the TOFS charity, and then some focus groups, interviews and activity sheets. You can see there that we ran 5 focus groups, 2 with adults with OA TOF, 2 with family members of people with OA TOF, 1 children and young people with OA TOF, 5 different interviews, and 2 people completed activity packs. They preferred to participate that way rather than speaking to anybody. And that gave us a real wealth of information that we were able to use and ensure that we were not just as doctors and healthcare professionals looking at what was important to us, but we were really focusing on what was important to the family. And so having looked at the outcomes that were relevant from the literature and the outcomes that were relevant to this group here, we were able to form a long list to feed into a Delphi survey, which I'll come on to in a moment. We had, going back to the international collaboration, really important that we had this true international collaboration, and we sought out to involve people from all around the world who could liaise with their patient demographic, their patient population, and made sure that the outcomes that we had identified from the systematic review and our patient events were relevant, and then they were able to feed into that and added additional outcomes to that long list. So once we'd generated that long list, initially of 54 outcomes, we fed that into the Delphi survey, and some of you may well have participated in that. The Delphi survey was sent to as many people as possible from all around the world, and it asked people to rate how important an outcome was to them. And the Delphi survey, the way that it does it is it changes the order that it asks you the different questions in, so you don't get everybody thinking, oh, well, that's really important, and then by the end of it you get a bit jaded and a little bit fed up and things are feeling less important by then, which can happen if you use the same order. So the software used in the Delphi survey ensures that it is randomly generated, that different people will have the answer those questions in a different order. So we did 2 rounds of the Delphi survey, and following that we progressed to a consensus meeting, and I'll go on to tell you more about those just now. So the Delphi survey, we did, after the 2 rounds of it, we had 175 respondents who completed both rounds of that Delphi survey, which we were really pleased with. You can see there 97 healthcare professionals and researchers and 78 people born with OA and TOF and their families, was how that was divided up. Reassuringly, we had 13 different disciplines. Of those 97 healthcare professionals, it wasn't all surgeons who were voting or all respiratory paediatricians, but there was a vast variety, 13 different disciplines. All 6 habitable continents were represented with 26 different countries, which was great to see. As a UK-based study, we were always going to get a large proportion of people from the UK participating in this study. But what was fantastic for the steering group to see was that over half of those who contributed to the Delphi survey in the healthcare professionals and researchers were from overseas, and again with the patients and families, just over half were from outside of the UK. So we really achieved our international aim. So once the Delphi survey was completed, we analysed the results of that, and the results were analysed in 2 groups. Healthcare professionals and research were analysed as one group, and then people with esophageal atresia, Tracheo-Oesophageal Fistula and their families and representatives were analysed as a separate group. If more than 70% of people in a group voted that the outcome was very important, it was classed as in. If less than half of the people felt it to be important, it was classed as out. And if between 50 and 7% of a group voted it to be important, it was classed as medium. And so we can see there that there were 54 outcomes in that first round of the Delphi. People could suggest outcomes to be added, and so that went up to 62 in that second round of the survey. Following that Delphi survey, the steering group reviewed all of those 62 outcomes, and in hindsight felt that 3 of them were not strictly outcomes and they were excluded, and a further 9 were amalgamated because it was felt they could be grouped together. So that meant that there were 50 outcomes that went through for full analysis. 26 of those were excluded because they didn't meet that criteria of being in. They were not classed as being important by both groups. 12 of those were classed as being out by both groups, and so they clearly went out. 11 outcomes were classed as medium by one group and out by the other group, and so they were also excluded, and 3 outcomes were classed as medium by both groups, and they were also excluded. If either group voted it to be in, then it went through to the consensus meeting, and there were 24 outcomes that one or both groups voted as being very important. 5 of the outcomes were removed at consensus meeting because they were amalgamated into other outcomes and felt that they could be covered by another one. And so there were 19 outcomes that were voted on at that consensus meeting. 8 of those were not felt to be important enough to make the final core outcome set at that consensus meeting by those votes. 8 outcomes automatically were voted as being very important and form part of that core outcome set. And an additional 6 outcomes required further discussion because they didn't meet our criteria of over 80% of both groups voting them in. But after discussion, then they were decided to be part of that core outcome set. And so we have 14 outcomes left in the outcome set. And there they are. I'll just give you a moment now to read through those. 12 of the 14 outcomes are relevant to both ages. 1 is predominantly relevant to children and 1 predominantly relevant to adults, and that's why it's been classified in this way. So there you have it, the first core outcome set for people born with OA TOF. And what happens now is that each of these outcomes is having a very strict definition applied to it and a way to measure it. And from now on, all research should include these outcomes and they should be measured in a certain way. So in future, we can compare outcomes, we can compare research studies and really have much better research in order to drive things forward. I'd like to acknowledge all of these people who have been part of this work. I'm sorry that I'm not there to answer any questions, but Nigel Hall will kindly ask questions. He's been involved right from the start. Thank you.